Good morning. This is Dr.P.M. Gopinath, consultant in reproductive medicine, SIMS Hospital, Vadapalani, speaking to you about infertility. Now we will be talking to you about male infertility. So usually the normal sperm count, what normally we just, when they do the semen analysis, they give a sperm count. So there are various parameters available in the semen analysis. Let us focus something on count. When the count is about 15 million and above, then we call that as a normal. 90% of the motility is there, it is normal. At least 4% has to be a normal morphology. So this is what we call it as a normal sperm count. So the man can have a normal sperm count, or he can have an abnormal sperm count. That is, there may be a defect in the count or defect in the motility or decrease in abnormal sperm. So what we call this, the second parameter is an abnormal sperm parameter. The third one, he may not have any semen, the spermatozoa sample in the semen given. That means azoospermia, that means no sperm in the given sample. So this is the three situations. One is a normal semen analysis, second is an abnormal semen analysis, third is there is no sperms at all. So let us see what we have to do with all the three. One, when the semen analysis is normal, we go ahead and then try to do a test, what is called as a postcoital test. At around 12th day of the period, when of his wife, they have a normal contact, and then after 4 hours they come and report to us. In the clinic, there is a small sample is taken from the cervical mucus and then looks for sperms. What this calls is a postcoital test. This is an age-old test. If the sperm sample is there in the cervical mucus, that means there is no interaction, so it is quite normal. If there is a semen in the sample and there is, all of them are non-motile, then there is an interaction. So this is the second step we do. Then we try to concentrate on the other wife's parameters to go ahead. If it is an abnormal semen parameter, the commonest cause is an infection. So what normally we try to do is give antibiotics. Here, for a male reproductive tract, we have to give at least 3 antibiotics. So something like clindamycin, doxycycline, erythromycin, like that, 3 different antibiotics has to be given one after other. So the rotation of antibiotic and frequent ejaculation. During this period, you should ejaculate either with a normal intercourse or by a masturbation. You should ejaculate. All the old samples will come out, assuming the fresh sample will be normal. Along with that antibiotic, we always try to give antioxidants. Some good antioxidant medical management will be given. Then we repeat the semen analysis and then check. If it has improved, well and good, we continue to concentrate on the female factor. Supposing if it has not improved with the antibiotic, then we have to rule out the next condition called varicocele. The varicocele is the venous congestion close to the testis, so in the spermatic cord. So this, when we do an ultrasound, we will be able to differentiate it, and the ultrasound with a Doppler will confirm the diagnosis. Even a clinical examination, it will be like a bag of worms when you palpate it. So once when you have a varicocele, when the counts are abnormal, then we go in for a varicocele ligation. It's a small surgery like an hernia, and it's only about some half an hour procedure. Patient will be able to go back home on the very same day, and then they will be able to get back to the normal activity within 5 days. When you do this varicocelectomy, then the chances of improvement is more than 60%. So after the first antibiotic therapy, failing which you try to demonstrate varicocele by a Doppler, and then if it is proven you do the surgery, we might improve. Then if it doesn't improve, then we have to go for the strategy of assisted reproductive technologies like IUI or IVF. The third category of abnormality, where there is no sperm, what we call it as an azoospermia. If there are no sperms, it could be because there is no sperm production, or it is being produced but it is not being transported normally outside. So how do we differentiate? What we call it as a obstructive azoospermia and non-obstructive azoospermia. If it is an obstructive azoospermia, it is very simple. We can just take a small testicular biopsy and then take out the good motile sperm from it and then plan for IVF in ICSI, and then they can just get a desired result. And if it is a non-obstructive azoospermia where the production is slightly deficient, and it is very difficult. In that case, before we try to do a biopsy, we look for serum FSH level. If the serum FSH level is more than 3 times, that is more than 15, then we say it is difficult to get the sperms out by a biopsy. Another important test is called Y chromosome microdeletion. So this Y chromosome microdeletion, they do a chromosome analysis of the Y chromosome in the long arm, and then there is 3 different zones, what we call it as a AFZ, A, B and C. In the 3 zones, there may be a deletion at A or a B or a C. If it is deleted at A, when the test will tell us, and it shows germ cell apoplasia, there is no chance for getting a sperm. If it is a B, again it is Sertoli syndrome, where there is no chance for just getting a sperm. Whereas if it is only C is deleted, this patient might be able to just give us a sample. When we do a biopsy, we may be able to retrieve a sperm. So one is by the size of the testis, second is the blood flow, third is by serum FSH, fourth is by Y chromosome microdeletion. We can select the candidate from whom we will be able to take a biopsy. We do a biopsy and take out the sperms. So when we do this sampling, what we call it as a TSA, testicular sperm extraction. A small nick is made in the scrotal sac. The testis is identified. A small nick is made on the testis, and then the seminiferous tubules is gently taken out without squeezing and given it to the embryologist. They will analyze and see whether there is a sperm. If there is a sperm, they will freeze the sample, and then the wife will be allowed to go through an assisted reproductive technology like IVF. After the eggs are retrieved, then the sperms will be thawed, and then they will be taken, they will be used for ICSI, from which we can get a pregnancy. So in short, male infertility by itself, 1/3 of the males are responsible, and in a couple, 1/3 is male, 1/3 is female, the remaining 1/3 is both male and female together. So that means in any given couple, when you do an analysis, more than 50% of the cases, the male will be at fault. So the male, we can just take a good clinical examination, advise them on a good dietary habits, regular exercise, avoidance of alcohol and smoking, a good nutritive food, fresh antioxidants, and then we can just try to just give them medications like antibiotics and then antioxidants, and failing which we can just take them for an assisted reproductive technology if the sperm count does not improve. And if there is no sperm, we can do the screening test like FSH, Y chromosome microdeletion. Based on that, we can decide to do a biopsy and then take this sample, and which can be preserved later on, used for IVF and ICSI for the wife. So there are lots of hope coming up. It is not all that hopeless. The man, there is no end to the research and analysis, and today there is a lot of hope. Please do not get depressed about it. Go back, take appropriate consultation, and then take the appropriate treatment to achieve your goal. Thank you.